Hi, everybody. We are going to give everyone just a couple of minutes to log on. Thank you all so much for joining us this evening. My name is Brooke McGivern. I'm a speech pathologist and the Director of Marketing and Communications here at Tim's Medical. And I am so excited to have Loredana with us this evening as she shares her expertise discussing the VP. So with that, a couple of housekeeping items, and then I will hand over the floor to her. If you are interested in obtaining ASHA CEUs for this presentation, it is eligible for 0.1 intermediate ASHA CEUs. We do ask that you stay for the duration of the presentation. If we go over the 60-minute mark and you need to log off, you can definitely do so. No worries about that. And we will have the replay of this event up within our website in about 7 days or so. So if you miss anything, you can log back on and watch it. And additionally, we'll need you to complete a survey for ASHA CEUs, which I will put into the chat, and then it will also be sent out to you via Zoom emails. So if you miss it, it'll be sent out later this evening. And then if you'd like a certificate of completion for this event, just send us an email at tims-univ@tims.com, and we will get that over to you. And with that, I'm going to hand over the floor, but if you have questions throughout the presentation, feel free to put them in the chat or the Q&A, and we will address them at the end of this presentation. Awesome. All right, Loredana, the floor is yours.
Okay, thanks, Brooke. I'm just going to figure out how to share my slides properly. And I think that, sorry about that. You get to see a little preview there. Brooke, can you let me know if my slides are viewable?
Yes, they look great.
Okay, thanks. All right, so I just want to thank all of you for taking the time out of your busy schedule to be here tonight. Some of us are up late. I'm on Mountain Time, so it's dinner time here in Edmonton. And I just want to thank Tim's and Brooke for allowing me this opportunity to speak about this area that I'm very passionate about. And without further ado, I will get into my presentation. So I have nothing to disclose. In terms of the objectives, and before I review them, I just want to review some of the terminology you might hear me use. So I say VP, and that stands for velopharyngeal. I will also use the term VPD, and that stands for velopharyngeal dysfunction. And now, in terms of my objectives, because this is a presentation focused on pediatrics, I will be talking about the development of the VP port anatomy and physiology. And I think that's really important because as pediatric clinicians, we are treating and managing patients as if they are moving targets. So development is obviously something that we need to think about. We'll move on to comparing a neurological VPD versus a structural VPD. And then finally, I'd like to talk about some solutions for swallowing and velopharyngeal dysfunction. So I have a biased opinion, obviously, but when I think about the VP port, it's sort of like the UES's underling. It lives in the shadow of the UES, who gets all the fame, but nobody really thinks about the VP port too much, except for me, obviously. If I took a poll of how many of you bypass the port completely when you're assessing the swallow-on fees, I'm sure there would be a large number of you who answer yes. In my job, I consider myself lucky because as an SLP, I get to work in both communication and feeding and swallowing. Essentially, I study the same body part for both functions. There's not a lot of research in the area of VP function for feeding and swallowing. So much of what I do is trying to understand how the VP port functions for feeding and swallowing while looking at research and communication and trying to apply that research and discover where it might work for swallowing. I'm going to review this study again at the end of this presentation, but there's a study by Arkenberg done in 2023 that discusses the overlap between neuromuscular control and speech and swallowing. This presentation is evidence-informed. I have tried my very best to integrate the best available research with my experience as a clinician. And for those of you who don't know, I've been working as an SLP in the cleft lip and palate clinic in Edmonton for over 10 years. So let's move on to the development of the velopharyngeal port. Between the ages of 4 and 6 months, the velum and the epiglottis move apart from each other, so they separate. The pharynx changes in length from about 4 centimeters to 12 centimeters as an adult. But what's interesting in terms of development is the anterior-posterior dimensions. So the distance between the velum and the posterior pharyngeal wall change very little from infancy to adulthood. The length of the hard palate reaches about 84% of its adult size by age 2, and the same goes for the soft palate, but it's 69%, but also by age 2. So there's a lot of growth that occurs from infancy to age 2, but then it slows from age 2 into adulthood. And this is pretty similar to other aspects of development, where the growth of the VP port is nonlinear. So I definitely feel like I have to mention the adenoids, as they are very important in terms of the velopharyngeal port. At age 6 months, or sorry, 3 months, the adenoids are able to be identified 18% of the time. And by the time a child is 5 months, the adenoids are 100% identifiable. In terms of a little bit on the physiology of the velopharyngeal port, the palate is definitely positioned very high, like other aspects of the swallow mechanism. So it's positioned very high in the airway. The levator muscles are also positioned very high, so high that in infancy they actually function as tensors. When they begin to drop, they obviously start to do what they're intended to do, which is to lift the palate. I do think that there might be some sort of clinical implication for this, as maybe some of that nasal regurgitation that we see in infancy, which is considered within normal limits, might be because the levators are behaving as tensors and maybe not forming as firm of a seal between the mouth and the nasal cavity during swallowing. So a little bit more on the aspect of physiology and VP port development. There's a study by Hoyt and Bunton, and this was done in 2017. And it looks at the development of closure for speech production, so not for swallowing, but they used RAM pressure. And what they did determine was by 19 months of age, that for a portion of the utterances that they were studying, the port is closed 90% of the time. They also determined that the port is closed by age 4 months, about 60% of the time for part of an utterance. And although there's nothing comparable in terms of the swallow, potentially maybe we can use some of this information to think about when the port might be closed for swallowing. And that 4-month age does seem to fall in line with when the velum starts to separate from the epiglottis and the airway actually begins to lengthen. One of the studies that the Hoyt and Bunton article cites is a study that was done in 1965. And that study by Bosma talks about how the port is open during the birth cry. And I just want to bring this to everyone's attention. So here's a video. This is a video of a 2-month-old who I saw in clinic. We were attempting to bottle feed, so we did have the bottle in his mouth, but he was quite upset with us and didn't want to do any bottling. So instead, he was crying, but this did give me some information, or just reaffirmed the idea that the velopharyngeal port is open during the birth cry. So if you do stop at the VP port and the baby is crying and you're thinking, oh boy, like they're not really getting great closure, that's not clinically significant. It doesn't mean that the VP port is impaired. It's standard and acceptable for the port to be open during the birth cry. Okay, so I just want to talk a little bit about the swallow mechanism as a peristaltic pump. Obviously, it's a complex neuromuscular unit, and some would say that the velopharyngeal port is the first step in being able to generate the right amount of pressure for the swallow to work properly. So we know that swallowing is a pressure-dependent system, and any change or any disruption in that system can negatively impact the swallow. There is the thought that poor bolus propulsion can be linked to impaired VP function. So given all of this, I thought I'd really like to have a look and see if reflux or nasopharyngeal reflux, if there's a link between that and aspiration, and have a look at the literature and see what it says. The next part of this presentation, I will do a very brief literature review. I contacted our librarian at work, and this person looked at a few databases. It yielded approximately 8 studies, so not too many, and only 4 of those studies were relevant. So the first study I'd like to review here is by Daya et al. In 2024. This was a prospective study, and it looked at 87 children. They used both clinical assessment and fees, and they did determine that nasal regurgitation is a predictor for aspiration. Their population data included those with a neurologic etiology and those with an anatomical etiology, and the neurologic etiology component was heavily based in cerebral palsy. The next study I want to review is by Chul Huynh et al., and it was done in 2017. This one was done on adults, and I included it as it was one of the only studies part of this search that looked at the relationship between nasal regurgitation and aspiration. Again, they looked at their patient population, included both neuro and structural, including head and neck. They looked at, they used high resolution manometry, and they determined that a lower VP pressure was found to be significantly predictive of aspiration pneumonia. The next study I want to have a look at is Reed et al., and this is a prospective study. They looked at patients who have a cleft palate, and they completed a clinical exam. They didn't report on anything in terms of aspiration, but they did indicate that nasal regurgitation is a strong predictor of poor feeding. And the final study I'll review is by Jad Churla et al. In 2009. And they looked at neonates in specific using manometry and video fluoroscopy. It was again a prospective study. On video, they saw that 4 babies had nasopharyngeal reflux, and 4 out of the 6 of those babies demonstrated aspiration. Again, the etiologies included in this study were mixed between neuro and structural, including chronic lung disease and stroke. So here's a quick summary of the literature. When you look at it, it does look like there's a strong correlation between nasopharyngeal reflux and aspiration. But what I will say is that the studies did publish aggregate data in terms of the populations that they report. So they didn't separate out the structural kids with dysphagia versus the kids who had a dysphagia due to a neurologic etiology. They also none of the studies included information on the development of the velopharyngeal port and or any of the development in terms of swallowing, actually, and that it changes throughout infancy. And yeah, none of them accounted for any of the developmental changes. The other aspect to consider is very limited studies. So only 3 of the studies that I looked at in terms of my literature search were usable and provided any information on links between nasopharyngeal reflux and aspiration. So very limited information out there in terms of the literature. Next, I just want to show you an example of a neurogenic swallow. So this child has an unrepaired cleft palate, or sorry, pardon me, has a repaired cleft palate. And as you can see here, is having, if you want to look up here in this area, I hope you can see my cursor, is having what I would consider severe amounts of nasal regurgitation, severe to moderate. I know it's not going completely out towards the nose or towards the nares, but there is a significant amount definitely moving up into the nasal cavity. And you can see that there's definitely poor VP closure. The other aspect of the swallow that is definitely hard to ignore is that there's a very significant delay. So the pharyngeal swallow is impaired. There's no aspiration seen here, but this patient is definitely at risk for aspiration. The next study I want to show you is a study that demonstrates a structurally impaired swallow with an unrepaired cleft palate. So this child is close to 1 year old and is using an adaptive bottle, so has some difficulty with suction, obviously. And you can see again, there's a significant amount of nasopharyngeal reflux moving up into the nasal cavity. But when you look at the swallow, the pharyngeal aspect of the swallow, everything looks really good. There's no delay, there's no risk of aspiration. I should say too that the neurogenic swallow in this example here, this patient is around age 3 and does have some developmental concerns. And she is also using an adaptive bottle and has been unable to transition to any type of cup and is unable to drink from a straw. So this bottle that this patient is using here for this neurogenic swallow is actually the same bottle that this patient is using here in the unrepaired, in the scenario where there's the unrepaired cleft palate. So what I do need to say is that babies who have a cleft palate and who don't have any other medical concerns, if they are provided with an adaptive bottle that helps them with their milk transfer, there's no difficulties with feeding and with growth and no increased risk of aspiration. So essentially, babies who have a cleft palate feed and grow just like their peers do who have a common anatomy, which I think is really important for everyone to know, and also may help us understand the swallow a little bit better, which I'll get into a little bit later on. When we look at nasal regurgitation with the intact swallow, so that baby where I showed you who was closer to 1 year old, who had an unrepaired cleft palate, one aspect of the peristaltic pump has been knocked out, but yet the rest of the swallow is intact and the baby is doing well. I think that we can liken this to what's out there in the research in terms of vocal cord paralysis or paresis, and that if that is present, we know that outside of any other difficulties with the swallow, we know that that alone does not impact the swallow negatively and that there's no risk of aspiration. I think this also illustrates the fact that swallowing is obviously not purely mechanical, that there's other things at play here. So it's not just about the peristaltic pump. The other thing to consider when you look at how this baby is swallowing really well is you do wonder how they're adapting. Is it the tongue base? Is the tongue base contacting the posterior pharyngeal wall and allowing the proper pressures to be built up? And that's what's keeping the swallow intact. And as I've said before, babies who have a cleft palate outside of any other medical concerns don't have any increased risk of aspiration. There's no correlation with aspiration. When we look at nasal regurgitation in a neurogenic swallow, what we see is that in this population, poor VP function might actually be a predictor of aspiration. And certainly when we see it co-occurring with other difficulties, such as UES, poor UES opening, or a delay in the swallow, that it is likely that the swallow is neurogenic in nature. When we compare a neurogenic velopharyngeal dysfunction in terms of swallowing, and when we compare a structural velopharyngeal dysfunction in terms of swallowing, it's not surprising that you'd have a different swallow. And it's not surprising that different etiologies demonstrate different swallowing difficulties. But I think it's really interesting to look at the two of them side by side because it might allow us to ask some questions. And like I said, think about swallowing and think about how we might understand the swallow a little bit better. So, for example, we have talked about how the pressure or the swallow is pressure driven and that the VP port might be the first step in that pressure driven swallow. But when we see a baby who has a cleft palate swallowing very well outside of nasopharyngeal reflux, we could ask ourselves how much of the swallow is actually pressure driven? How much pressure input is necessary to trigger an effective swallow? We can see that clearly it's likely that these babies are adapting other than using this adaptive bottle. The adaptive bottle definitely doesn't eliminate nasopharyngeal reflux. What the adaptive bottle does is allow the baby to transfer milk properly. But given that they're still experiencing nasopharyngeal reflux and that the port is definitely not partitioned or able to partition the mouth off from the nose, does their swallow modulate in the same way it would if you were swallowing a cold liquid bolus versus a small bite of solid food bolus? We can also ask ourselves, what does this tell us about brain plasticity? And along that vein, how do these babies who have a cleft palate adapt? So is it the tongue base, like I was talking about before? And if it is the tongue base, and this is a difficulty, if we work on improving tongue-based movement, could we essentially, for some kids, improve their swallow? So on that vein, what does this tell us about therapeutics? And if we understand how these babies are adapting, could this help us remediate certain dysphasias? So that's the first part of the presentation where I talk about how nasopharyngeal reflux can be a predictor in certain situations, and how babies who have a cleft palate adapt to nasopharyngeal reflux. The next part, I want to look at some specific examples and clinical applications when assessing and treating the velopharyngeal port. The first thing I want to talk about is notching on scope. So every once in a while, I get a referral to the clinic saying, please examine the palate. I've seen this notching on scope. We're wondering if it's a submucous cleft palate. I wanted to show you exactly what this looks like. So this is an older child whose cleft palate was repaired overseas. And notching can happen in the context of a cleft palate, but it actually can also happen outside of a cleft palate. And as you can see here, so this is the port, obviously, but you can see the two bellies of the velum, and it looks like there's a cleft actually on the nasal velar surface. So I just want to talk about a study by Perry et al. Done in 2024, and they looked at sensitivity and specificity of velar notching on scope. Now, this was done specifically for patients who have a cleft palate, but I do think we can take some information from this study. What they did determine was that velar notching, which was exactly what I just showed you in the previous slide, is not a useful indicator for levator palatini dehiscence, and they looked at that on MRI. So essentially, if the actual levator is split, what happened is when they just used notching, they determined that there was a lot of false negatives, which would indicate that if you just use notching, then you're missing some of the patients that actually might have a difficulty. But what I really think about when I think about notching, I actually don't think it's clinically significant at all. So I haven't really found much of a link between notching and any difficulties. And if there is notching, there's really no pattern to it. So what I would say is if you do see it on scope, I would encourage you to just manage that clinically. What you want to do is you want to, in babies, ask about the baby's efficiency to be able to bottle. So how much are they taking and how quickly do they take it? Do they take that in a reasonable amount of time? You also want to ask about nasal regurgitation. And it's really important when you're asking about nasal regurgitation that you ask about when it is occurring. So if it's happening with emesis, that is not clinically significant. If it's happening during breastfeeding or bottling, or if it's happening in a child who is no longer breastfeeding or bottling and they're sneezing it out, or if it's happening during meals, that definitely is clinically significant. But certainly we don't think anything of nasal regurgitation when it's happening during emesis. If those things are happening, then nasal regurgitation, like I said, during meals, and if efficiency is poor for those babies who are bottling, then they might need a referral to a VPD clinic or a cleft lip and palate clinic, whatever's available in your area. In the absence of those clinical symptoms, if you do see notching, what I would do is I would just counsel caregivers on what to look for regarding velopharyngeal dysfunction in both feeding and swallowing. So feeding and swallowing, again, that would look like poor bottling efficiency or nasal regurgitation during meals. And in terms of speech production, are you hearing hypernasality, nasal air emissions? If the child is developing, are they only using M's and N's? And I would encourage them at that point, if they're seeing those things, to connect with their primary care provider who can provide them with a referral. The other thing you want to do is do a really thorough oral exam, which I'm going to talk about in a little bit more detail on this next slide, actually. So in the context of a submucous cleft palate, so not a palate, a cleft palate that would be easily observable to the eye, but essentially, the three things that you want to look for are first the zona pellucida. So that would be a bluish tinged line that usually, or zone, sorry, that you would see at the midline of the palate, and then a bifid uvula, so a split uvula. So the zona pellucida and the bifid uvula are optional and possibilities. But the one thing that definitely needs to be present if the child or whomever has a hard or has a submucous palate would be a hard palate notch. Now, I really like this picture on the right hand side of your screen. So essentially what it shows here is the levator muscle, and it shows the hard palate without the mucosa covering it. So what you would do in an exam is run your finger along the midline of the palate, and you would feel a notch, which would be this V here for the levator. I mean, sorry, on the right-hand side of your screen, where the levator would be clefted along with the hard palate. And that notch is definitely a sign that there's a submucous cleft palate. Not necessarily that there's any clinical implications. People can have a submucous cleft palate without any clinical implications, but if you do feel that, you know that in terms of the anatomy, that one is present. I should also say too that infants, this can be difficult to feel because, as we already discussed, the anatomy is quite squished together. Um, and it does become easier to palpate as the child matures. So I just want to show everyone what this was: an occult submucous cleft palate. So one that this child did not have a bifid uvula or a zona pellucida, but did demonstrate this amount of nasal regurgitation on video. So this is thin liquid. This is with a standard bottle. This is not an adaptive bottle. But when I look at this child is more than 5 months old. When I look at this amount of nasopharyngeal reflux, that if I saw this on video, that would prompt me to have a closer look at the palate. If I couldn't palpate a notch, I would um, I would definitely look at efficiency. And this child, looking at their efficiency, probably needs an adaptive bottle, and I'll show you what the half nectar looks like. So again, this is a non-adaptive bottle, and you can see that this child cannot get any transfer with even just thickening it to only half nectar. This is someone too, if you're not the person who is in charge of the VP port, if you can't feel the notch, I would definitely manage clinically. And then I would also send a referral to a clinic who would be able to follow this child and ensure that they're managing from a VP port perspective. Okay, so I talked already a little bit about the adenoids, and obviously these are very important as they are a structure in the VP port for certainly for our pediatric patients. During the first year of life, the adenoids increase in size, and we've already discussed that a little bit. In infancy, by the time they're 5 months old, you can definitely see that there's adenoid tissue there. By age 8, some report by age 8 and some report actually by age 5 that the adenoid pad begins to decrease. So this is what I'm talking in terms of adenoid involution. It's very rare, but there are sometimes some impacts to resonance and VP function in terms of swallowing, which I'll show you some examples on scope. The next slide, I just want to show you an example of what a large adenoid looks like. So you can definitely see here that the adenoid tissue is really protruding into the port and the velopharyngeal port. Sorry, and the velopharyngeal port, the pharynx. Unfortunately, I am getting this patient to speak. This patient still doesn't have adequate closure and has some resonance issues, but that's because there's not enough stretch in terms of the velum. I think what you can also appreciate here is patients who have VP dysfunction for whatever reason should never had their adenoids removed, or if they are removed, the adenoid remnant should remain, just because many patients can be quite dependent on it. Now, if you look at taking out the adenoids on this patient, that would substantially increase the VP port gap. Okay, so I just want to get into a case example for adenoid involution. There was a 15-year-old male who was referred to our clinic, and he came because he was complaining of nasal regurgitation at least once a day. There was a quite significant impact on his quality of life. He would not eat food or drink with his friends at lunch. He wouldn't be able to go to the mall and hang out in the food court with his friends. So the ENT who was seeing him, who had prescribed Nasonex for his sinusitis and rhinitis, wanted a review by speech pathology. We'll get into his scope. Oh, I should mention too, I did do a clinical exam in my office. I didn't see any overt nasal regurgitation, which isn't uncommon. I don't find clinical exams overly telling in terms of nasopharyngeal reflux. It's usually the scope that gives you the best information. And certainly on scope, you'll see here that there is some occult nasal regurgitation. So right here, in all of my scopes, and as I have already alluded to, I look at the same body part for both speech and swallowing. So here I'm actually getting him to speak. He has just a tiny gap there, nothing too crazy. Like I said, again, this is during speech, and you'll see during swallowing. So this is when he starts to swallow. And I have it. Yeah, so you can see a little bit of the water coming up there that he's drinking. What I think is really interesting about this when you look at the speech compared to the swallowing is there's a lot more recruitment of the velum during the swallow. So it's moving quite a bit. It's actually sometimes completely obscuring the camera view, but you can definitely see, and I'll just forward it a little bit here to show you where he has the yeah, so you can see it's kind of coming up on the back there. I'll show you again. Yeah, did you see that? Hopefully you saw that. There was some water coming up. So what we recommended for this young man was a furlough-palatoplasty. So it was a surgical recommendation. And because he has quite a bit of movement in his velum, what we thought might help him is just to give that velum a little bit more length. So I'm not a surgeon, and I'm going to explain this just from the view of a speech language pathologist. But when I looked at the scope, like I said, there was a small gap, and what we thought would help is if he just had that tiny bit more to close things off and maybe stop the food and the drinks from coming up. So essentially with this surgery, you cut a Z into the palate. Now the picture here shows a the cuts for an unrepaired cleft palate, but you can also do it in a repaired cleft palate. It would be essentially the same type of cut, but you cut a Z shape into it and you reorient the muscles. And like I said, that gives the palate a little bit more length. There's some thought too that it might increase the thickness and the bulk of the palate. And he did go for the surgery, and he has been back to see me and indicated that things are going really well in terms of his swallowing, and he's feeling a lot better, and he's able to eat lunch with his friends, which is great. The next case I want to talk about is a 16-year-old female who had adenoidectomy and tonsillectomy, and she had this secondary to sleep apnea. So she did not have a cleft palate, and I should mention too the case before that person did not have a cleft palate. It's just that his adenoids had involuted. This patient that I'm going to show you now, they removed the adenoids and didn't leave any adenoid remnant. In the office, when I had to listen to her, her resonance were within normal limits, but she did complain of intermittent nasal regurgitation. And so that's why I received the referral from ENT. I'll show you her scope. So I think just very briefly, I'm getting her to say some speech sounds, but right away, right away you can see that there's some liquid coming up when she goes to swallow. We actually offered her the same type of surgery, which was the furlough-palatoplasty that I discussed in the previous case, but she wanted to think about it and she let us know that she would contact us if she wanted to proceed. I am a bit fuzzy on the details. I have redacted all the identifying information, obviously, from these cases, but I don't think she actually came back to go through with the surgery. I should mention too that if you have a patient who's had an adenoidectomy, you can expect a lot, and if they have velopharyngeal dysfunction right after the adenoidectomy, you can expect a good amount of spontaneous recovery for up to 6 months. Around 6 months, it begins to slow, and typically the recovery is complete by a year. So if it's still present by a year, that means you might have to do something about it. Okay, so moving on, I wanted to discuss a case that looked at Treacher-Collins. So Treacher-Collins, for those of you who are a little bit less familiar with, is essentially hypoplasia of the upper jaw and mandible and the upper part of our cheekbones. They may or may not have a cleft palate, and there's no impact on cognition. I will say that many of these patients have resonance difficulties or velopharyngeal dysfunction due to the structure of their airway. So here's a picture. The other thing I should mention is they do have a small mandible, so that can cause some feeding difficulties along with the velopharyngeal dysfunction. This example is of a female who's in her teens. She is known to our clinic. She has a cleft palate. She came back to us though because she had recently had a surgery on her jaw by the maxillofacial surgeon who found that there were many tonsil stones, and as a result, she had quite significant halitosis. When I listened to her in the office, her resonance was significantly impaired, but interestingly, she did not report any overt nasal regurgitation. It was really actually the tonsil stones and the halitosis that brought her to me. She has a history of a tracheostomy and G-tube. I'll show you her scope, which I think is really interesting. I think right away you can see, so here's her velum, and you can see the tonsil stones at the back there that are embedded within the adenoid tissue. Again, I'm getting her to speak here. You know, there's quite a significant gap. She's having, she has a little bit of velar movement, but there is essentially no partitioning of the mouth from the nose while she's speaking. I'll just fast forward a little bit to the swallowing piece. So here she's swallowing some thin liquid. And you can see it coming up. It's interesting because when I had a look at this scope at first, I thought, oh, is she getting good closure? But her palate is so short that when I tipped the scope just a little bit further down, what you're seeing at the bottom of your screen there is actually her tongue base, and her tongue base is contacting the posterior pharyngeal wall there. So I should mention too that yeah, you can see the puree, the applesauce is coming up quite a bit. So not surprising that she's getting food trapped in that adenoid tissue there. What we did offer for this patient is actually, before I get into what we actually offered, what I would say here is that when you look at her gap, it's quite significant. It's quite large, quite severe. So what you know, would typically recommend with a very large gap like that for both swallowing and speech would be a posterior pharyngeal flap. Again, I'm not a surgeon, so I don't want to get too much into the nitty-gritty of the surgery, but essentially what the surgeon would do is take a piece of tissue off the posterior pharyngeal wall and then attach it to the nasovelar surface. So you'd have a bridge, and on the right and left sides of the port, you'd have two breathing holes. Now, this patient, that's not really a great option for her. She has a history of having a tracheostomy. She has a complex airway because of the TCS. So what we thought was we should start with a furloughplatoplasty because a risk of that posterior pharyngeal flap surgery is actually sleep apnea and breathing concerns. She is going to go for ahead with the furloughplatoplasty, which is great. Hopefully that will, because her palate is so short, we're hoping that will give it a little bit more length and she might be able to close things off a little bit better. In the meantime, before she goes for any surgical intervention, I recommended regular nasal rinses. We're also going to try and do some resonance therapy, which I'll talk a little bit about in the next slide. And the other thing that I do sometimes recommend is positioning. So sometimes if you have the patient lean back a little bit, this can reduce the nasal regurgitation. I I haven't looked at this under instrumental assessment too often. Patients report that it helps sometimes, but I'm not, you know, really attached to that recommendation as I'm not entirely sure it helps, but it is something that I do talk to the patients about, and I'm honest with about in terms of a recommendation. In terms of the resonance therapy, I talked about this study at the beginning of the presentation, the study by Arkenberg. They looked at typically developing children and evaluated neuromuscular control with SEMG. And they did this during parallel speech and swallowing tasks, which I thought was really interesting. So it was found, and this is not surprising, that there are definitely separate elements of neuromuscular control. But while there are separate elements, there are also shared elements. So what I wonder in these patients, and since, you know, as a speech pathologist, like I said, I look at two different ways to function, which is speech and swallowing, but I look at the same body part. I do think it's reasonable to be curious about whether or not resonance therapy can help improve the swallow as well. Okay, so the last case, I want to save time for questions, and I'm just watching the time tick down. The last case I want to talk about really quickly is a patient who was referred to me by respirology for a difficulty with his palate. He has some chest sequelae, so respirology was concerned about his swallowing. And on oral exam, this is what I saw. So hopefully you can all see that, but the palette is deviating. Now I'm really bad with rights and lefts. So deviating to his right, which would indicate weakness on the left side. He was also seen by plastic surgery and found to have paresis of cranial nerves 9 and 10. We did a clinical exam in the office. He didn't have any coughing or choking or any signs of airway compromise, but he did have a self-imposed hard swallow, which I thought was really interesting. And in a clinical exam, I thought, oh, that must be because he has this paresis and he's having trouble moving the bolus through the pharynx. So because of all of that, we decided to proceed with video fluoroscopy. And here's what we saw. So essentially a really nice looking swallow. So that's thin. This is puree. I mean, a tiny bit of residue, nothing that I would even consider concerning. And then I thought, okay, well, I'll have a look at the AP view. Maybe there's something there. Maybe I'll see some sort of asymmetry. Again, this is thin. You can see there's just a tiny bit that piriform sitting in that piriform, which I thought, oh, okay, well, that means that that's on his side that's weak, but that's actually not. It's his left side that's weak, so it's on the opposite side. And this is puree. I think what's interesting about this case and the reason I wanted to show it is when you look at the oral exam, you think something about the structure and that I thought, oh, he probably does have some nasal regurgitation or some difficulty with his swallow. But despite that, it looks like he's compensating quite well and he is able to partition his mouth off from his nose. And you know, it doesn't necessarily mean that when you see that type of structural difficulty, very much like the babies who have a cleft palate, that their function is really going to be significantly impacted. So with that, I'll move to my last slide. So I think that, you know, I hope from this presentation you have a better appreciation for the velopharyngeal port. What I'd like you to think about is that when you see nasal regurgitation, it's definitely not a universal predictor of aspiration, but can be significant in different populations. And when you're reading those studies, or if you're doing those studies, it would be great if that population data could be separated because we know that the swallow is different for different etiologies. I'd also like you to think about the fact that if you see something, a structural impairment, that doesn't always link up to exactly what you think you might see in terms of function. So a lot of times too, babies who don't have, or people who don't have a really strong grasp on babies who have a cleft lip and palate, they have a sense that right away they're not going to be able to feed and they need to be transferred to the NICU and they need all types of intervention from a feeding and swallowing perspective, when that's not true at all. Like I said, outside of any other medical difficulties, babies who have a cleft palate, as long as they have an adaptive bottle, can transfer milk very effectively and can usually feed and grow just as their peers do. The other aspect is if you are somebody who is looking at both speech and swallowing for similar body parts, I think, or for the same body part, I think it would be really interesting to see how intervention in one may impact the other and how the other aspect might start to function. Could we see some improvement? And what does this tell us about what we need to do from a rehabilitative perspective? And that is that's that. So should I stop sharing here, Brooke?
There's actually some question
Okay,
about there's several questions, but there's a
okay.
question about one of your case studies, but I'm going to start at the top. So the first question is, what is the birth cry? If they're old enough to be feeding, do you mean infant cry when you use the term birth cry?
Yeah, infant. So it would be, I think I'm crying in general, but what that study referenced was less than 3 months. I think especially less than 3 months, it's not clinically significant. But I also think, you know, even as the child gets older, I've definitely scoped enough 4-year-olds and they've been crying and I've seen that it's open.
Awesome. The next question is, what bottle did you use during your studies? I know sometimes you use an adaptive bottle, so I'm not sure which Nicole is referring to. So just in general, I guess, which adaptive bottles did you use, and then which just regular bottles are you using?
Yeah, great question. So as I said, I don't get any money from anybody. But the bottle that I use in the clinic is the Dr. Brown's specialty feeding system. So definitely, you know, that bottle, I don't actually use any other bottles. Once in a while, if there's a bigger baby, I might use this other pigeon nipple, but really every single baby since the Dr. Brown's has come out is on that bottle. It works quite well. It's self-driven. You don't have to, we used to use an assisted delivery bottle where the caregiver would squeeze that into the baby's mouth. The Dr. Brown's works a lot better. And all of the studies that I showed you today where there were infants bottling, that's all the Dr. Brown specialty feeding system.
So, um, the next question is about the notching. When you were you had a case study about that. Danielle asked if you could potentially go back to the video and highlight the notch with your mouse just to show people what notching is.
Sure. Let me, okay, oops. Can you see my slides again?
Yes.
Okay. I think I was using my mouse the whole time, but I was using it on the presenter view, so I apologize. I just realized that now that I was showing people things, but it probably wasn't working. Can you see it now? Can you see my mouse?
Yes. Yep.
Okay. I'm just going to move my, all right. So, oh, sorry, this is the large adenoid. Give me one sec. Okay. Sorry.
That's okay.
So do you see that there's the two bellies? Can you see my mouse?
Yes.
There's the two bellies, and then you see here there's like a cleft. Usually that surface is nice and smooth.
Awesome. And actually, the next question was about adenoids. So,
Okay.
Danielle asked, are there any rating scales that you use for measuring or quantifying the size of adenoids?
Yeah, that's a great question. I don't use any rating scales. I look at the closure pattern and whether or not that person is really dependent on the adenoids to seal off the mouth from the nose. And I leave the categorization of that, whether, the ENT wants to say that's 3+ or whatever. So I defer to the ENT on that.
Okay. Let's see here. Have you noticed more pharyngeal residue on MBS in children who have cleft palate?
I haven't. No. If you're talking about babies or children who have a cleft palate who are healthy, I don't notice more pharyngeal residue. No.
Okay. This question is from Katie. She said, have you noticed any trends with swallowing in the 22q-DS population?
Yeah, I meant to include a case study on this population in this presentation, but I just ran out of time. Like I just had so much to say. So, in terms of trends, they absolutely have that population definitely has pharyngeal residue. I mean, they have an impaired pharyngeal stripping wave. I do see lots of resonance difficulties. I do see lots of velopharyngeal dysfunction in terms of the swallow. It can vary. Some patients are enterally fed and some patients are fully orally fed. It does vary. Can be very individual, but there are definitely some specific things about the swallow that I notice.
And the next question is, did I correctly hear that you say that some nasal regurgitation in infancy is normal?
Yeah, I think in early on in infancy, when the child is quite young, like less than 3 months old, I think that it's not uncommon to see that. I personally, like, I mean, this has not been tested. This is my opinion as a clinician. But I do think it could be because like I said, that levator isn't really doing the job it's intended to do, and it doesn't seal the mouth off from the nose. So I would say 3 months or younger, you would, a little bit of that would be within normal limits.
The last question that we have at the moment is, how do you target tongue-based retraction in the pediatric population?
So that's a great question. So I don't. It's just something I've been thinking about, and I'm, just wondering if maybe for some of those um cases where I see that there's a neurogenic swallow and the child might be appropriate for something like that, that might be something that I might look at. Again, like it's very difficult because there's no evidence on that. And also in pediatrics, the thing to consider is many of our children have difficulty understanding, so it's really hard to sometimes implement those therapeutic interventions. But it is something I'm curious about. So if anybody's done it, I would really like to chat with you.
Definitely. Let me make sure. I think we actually got them all. If anyone else has, oh, here we go. We do have one more question. Okay. When you talk about nasal regurgitation being a predictor of aspiration, are you including the cleft palate population in that statement?
I would say no, no. So those videos that I showed you with the baby who has a cleft palate, I do not think it's a predictor of aspiration. And from my experience as a clinician, like I said, babies who are healthy, who only have a cleft palate and they're using an adaptive bottle, they're not more at any more risk of aspiration.
Awesome. I think we answered all of the questions, but if anyone has any questions that you didn't get a chance to ask, or if you're watching the replay and you have something pop up, feel free to send us an email at tims-univ@tims.com, and we will make sure it gets answered for you. And just a quick recap, if you are wanting ASHA CEUs, just fill out the survey. I put it at the top of the chat here, but it will also be sent out via Zoom, and we'll have that submitted to ASHA within 7 days. So today's Monday. So by next Monday, just make sure that's submitted. And then if you'd like a certificate, just email us at tims-univ@tims.com. There was a lot of really positive feedback from this presentation. So thank you, Loredana, for being the first person to present about pediatric related swallowing issues for Tim's University. And thank you all for being with us this evening. Have a great night, everybody.
Thank you.
Bye.
Bye.